Okay, good morning everybody, thank you for coming. It's really good to see everybody here. I'm really proud of what we've achieved, the help that we received from Kathy, Mark in London and also CCLG for helping to put this day together. I just want to say thank you. For those of you that don't know me, you might have seen me through the Bethany's Wish charity, or you might have spoken to me on email. I'm Bethany's mum. As Jessica has mentioned, Bethany's story isn't a happy one, but this is why we're here. This is why I've got the passion to do what we do, and this is why I want to make a difference. I just want to tell you a little bit about our story. So, my daughter Bethany, she was age 4. She never had any health complaints, never noticed anything that was really abnormal. She had a few fevers, nothing that would make you take her to the doctors. Over a period of about 2 to 3 months, we noticed that her tummy appeared to be slightly swollen, but we just assumed that she had a healthy appetite. My husband comes from an African Caribbean background, just assumed that she had a big bottom, big belly, kind of that build. It wasn't until another mother from one of the schools that Bethany went to, her little boy was treated for neuroblastoma, and she took one look at Bethany and said to me that I needed to take her to the doctors, but she didn't think it was right. So we booked an appointment with a GP, took her along, just expecting really to see that it was maybe an allergy, maybe an intolerance. I was imagining these African children had big bellies that didn't get enough nutrients, and I thought, well, that's it, definitely. It was then that we were taken into a room. They found a large mass, as they called it. At that point, I didn't really understand what a mass was. They said it was likely to be a Walden's tumour. We were transferred to Birmingham under the care of Dr. Morland, who's in the room today, and also Sophie Will, who's here also today. She was diagnosed with stage 3 intermediate risk of right-sided Walden's tumour, and we started on the CCLG trial, which I think is 2001, is that right? And she started a 4-week course of preoperative chemotherapy with vincristine and actinomycin. To begin with, she was very poorly. We completely just thought that our world was coming to an end. To hear that your little girl has got cancer, you just think that you're the only one in the whole world that it's happening to. We'd never heard of Walden's tumour, we'd never heard of cancer, we'd never met any child that had had cancer before, so it was a complete shock. And I think until you're thrown into this world, you never really notice any children with cancer, or even do any research to find out what the statistics are, how many are diagnosed. I think most people are just completely oblivious to the fact that children get cancer. The biopsy showed that she had stage 3 intermediate risk, so we started on a treatment regime. She had right-sided kidney removal, vincristine, actinomycin, doxorubicin, and we also had radiotherapy to the whole of the tummy. Basically, when your child is diagnosed with cancer, I think the main things the parent goes away and does is go to Google. We basically research anything that we can find on this cancer. We research any treatments from around the world, what's the best thing to do, are the doctors doing the right thing, do they know what they're doing? And also you become very critical, it's your child, it's your baby, and you want to have the right thing done, you want that people know what they're doing. You're thrown into a world where you're given consent forms, clinical trial forms. Your knowledge of this at this point is vague. Your head is just full of the fact that your child has cancer. There's nothing else that can get into your brain at this point. But you're forced to sign the consent forms to have chemotherapy, to have surgery, and it's just a very scary time. You soon get used to what we call the oncology family lifestyle. You always have a bag packed ready to go. You can always get yourself ready in about 2 minutes and straight to hospital. You kind of sit there waiting for the temperature to go above the magic 38 degrees. Sort of play it around for half an hour, thinking that it'll go down, when you know that you're going to go to the hospital in the next half an hour after that. Also the neutropenia bubble, as I like to call it. Your child can't basically go anywhere because you're scared of germs, you're scared of people coughing on your child, you're scared of taking them to school, to the cinema, to play with their friends. It's just a very hard thing to live with. But oncology families, as I've met quite a few from doing this, they seem to adapt quite well. Their family is usually very strong, although there is very challenging times during the treatment. And mostly you have a lot of support from your family and friends. Also, I found parents become an expert parent. I think it's fair to say that most parents know more than some doctors that are treating their children about their cancer, because they've researched so much, especially in shared care centres where there might not be the experience there of being in the main hospital. I think it's important for doctors, researchers to listen to parents. They know their child, they know when something's wrong. Even if the clinical evidence isn't there, you still need to listen to the parents and take their views on board. This is just a quote, as I say, to hear that your child has cancer is one of the single most hardest things to try and comprehend. You never think that it could happen to you, and I think this is extremely poignant quotation to say. Bethany completed her treatment in 2009. We were given the news that she was all clear. As Jessica mentioned, 90% of children with Wilms go on to make a complete recovery. Wilms is considered one of the best cancers to have. I've heard that it's been compared to diabetes, that they would rather have diabetes than Wilms tumour, because diabetes is a long-term condition, Wilms tumour is fairly easy to treat. For me particularly, this is really hard for me to digest, and it's one of my pet hates, as it were, for Wilms. We had follow-up scans to abdomen and the lungs on a 3-monthly basis. We managed to get to 18 months. We were all clear. We thought, that's it, we're home free. We've got past the year. The scans were going to reduce after that point. Unfortunately, only 1 month after having a clear chest x-ray and abdominal scan, we noticed that Bethany had some blood in her urine, and then a relapse was confirmed in the left kidney and also the lungs. So this time round, I think the first time the treatment was pretty... I think we felt that Bethany had cancer, but we didn't really have a lot of treatment. We weren't really in hospital a lot of the time. She didn't really have a lot of blood transfusions. I think sometimes we felt, wow, she's got cancer, but she doesn't really have cancer because the treatment's that simple. But this time round, it was definitely what I call the belts and braces approach. Everything was thrown at her. We were treated with carboplatin, cyclophosphamide and etoposide. She had GCSF injections to increase her white cell counts. She had stem cell harvest and stem cell transplant. Was treated with high-dose melphalan. We had multiple blood and platelet transfusions, admitted numerous times for infections, and during the period of the treatment we noticed increased and prolonged neutropenia. This time around we spent the majority of our time in hospital, and it was a very scary time for us. We were lucky enough to have a brilliant surgeon, Mr. Arrell, is that his name? Yeah. Brilliant surgeon. He operated the first time on Bethany. The second time he was around, he'd just come back from Afghanistan, and he was able to dissect the tumour in her remaining kidney, took away about 3/4 of that kidney, leaving her just 1/4. The plan was for dialysis and an eventual transplant of that kidney, because there's only a limited amount of time that 1/4 of a kidney can work for a whole body. And she also had radiotherapy to both lungs. In February 2012, we were given the good news that we were in remission. There was no evidence of disease in the lungs, and the area around the kidney that they removed was all clear. We truly thought that this was the time that we'd beaten the disease and it wouldn't come back. I know that the doctors had reservations about that, but we were really, really positive this time. This was going to be the time that Bethany was going to survive. We also got the good news that she didn't need dialysis. Her kidney was working brilliantly. On 1st of August 2012, a routine scan showed that she relapsed again to her left lung. Surgery was ruled out due to proximity of the tumours to her major vessels. We had numerous discussions with both the team at Birmingham and Kathy in London, and also consulted people in America to try and find some treatment somewhere that would work. There's no further relapse protocol for Wilms tumour after the first round. There's no research evidence to date of any chemotherapy agents which show curative results for relapsed Wilms tumour. Topotecan, which is one of the chemotherapy agents, was offered, but again there's no evidence to show that this would cure Bethany. I consulted doctors around the world, USA, I think there was somebody in Germany that I spoke to. I just spent the whole time on the phone and the internet just trying to find something. And then we planned for oral etoposide for the meantime, just so we could go on holiday and so that Bethany could enjoy her quality of life. And then unfortunately, on the 12th of October, we lost Bethany, which is only 2.5 months after she relapsed. So for me, the main thing that I want to do is just raise awareness of Bethany's story, raise awareness of Wilm's tumour, and also look at how things could be done different and trying to get the parents' view across. I know that I've only got limited experience of Wilm's tumour. I know that there's a lot of children's cancers that I don't necessarily know about the treatments for, but I feel very passionately for parents and that their view should be considered in research and that their view should be considered when treating children. Kathy's been doing amazing work in London with DNA profiling to identify high-risk tumours and also tumours that would relapse. And also biopsy and tissue banking for future research wasn't available for Bethany's tumour, which needs to be changed because they need to be able to keep hold of these tissue samples. They need to be able to analyse them for many years to come, not just for the immediate future. Also, in my case, the way that I see Bethany's story is that there's a difference between somebody like Bethany, who has a stage 3 favourable Wilm's tumour, and somebody that goes on to make full recovery. I want to know what the difference is. There's a difference there somewhere. It just needs a research trial to find that answer. We also desperately need new drugs for relapse treatments and need to understand the biology of tumours and earlier diagnosis. This slide's just about what parents want. It's just my view, it's not everybody's view. I think that parents realistically want new trials, they want new drugs for childhood cancer. There's a limited access to new drugs. There's no initiatives for people to develop new drugs for children. We need to improve awareness of childhood cancer with the government, with everybody. People need to be aware that children do get cancer. When they're treated, we need less jargon, we need less clinical words, we need it put plainly so that parents can understand it at a time that they don't want to understand anything else. And also considerations for professionals, listen to parents, they know their children, and improve shared care by shared care hospitals as well. Have experts there that are available so that parents feel that there's somebody there who knows what they're doing and they know how to care for their child. Standardised imaging, I think there's a bit of a discussion about MRI or CT for different types of tumours. I think if we had a standardised imaging protocol for specific tumour types, this would greatly help and would make a massive difference in diagnosis and also relapses. Improves access to new drugs. We need to encourage greater financial incentives for companies to develop drugs for childhood cancer. And we need to provide incentives for researchers as well to conduct trials so that there's the need and the want there to make a difference. We also need to be able to share information between the USA and the rest of the world. This is just a quotation from a poem that I found. I'll just let you read that, it's probably easier. And finally, I'd just like to close with, together we can make a change, together we can save 100% of children from childhood cancers. I really do feel that together we need to fight to make sure that children are not lost due to financial limitations or lack of research. Paediatric cancer research is the answer to the cure, so together we can make that change. Thank you.
Thank you, Angela. I mean, it's obviously an incredibly sad story, and it's amazing that Angela is so brave to be able to divert her energy so soon after losing Bethany into this amazing endeavour. And I'm just amazed, how many people she's mobilised to come and talk about this topic. And I hope we can go away at the end of the day with some really concrete plans on how we can work together to really start to change things for the better in the UK.